Hi everyone, this is Lauren Egan for our Module 6 discussion. This week we are looking at pain theories and management and also drug abuse um, after folks have started with their pain management. Specifically for this discussion, we're supposed to look at opiates and how we can identify and help manage people that are abusing opiates. It seems that according to our text that abuse is the highest for opiates and prescription drug abuse for the age group of 18 to 25. And they found that a lot of even young folks, teenagers, are getting these prescription drugs and abusing these prescription drugs from their parents, whether by, their parents are not using safe drug um, storage or that their parents are actually giving them to them and they're combining with them with drugs and alcohol, and that is one of the leading causes of death in teenagers also. Um, some of the assessment findings that can indicate substance abuse as a whole, there is a wide range of symptoms that we might see, but because we're specifically looking at opiates this week, we can see the central nervous system slowing with opiate abuse. So you can see severe bradycardia that can result from a stimulus of the vagus nerve that an overabundance of opiates in your system can have. There are going to be possible track marks. I know I've seen a lot of rashes on people that are just taking them orally. I've seen a lot of rashes and just strange skin conditions that we can't attribute to anything else. Of course, pinpoint pupils if they're on their high, but if they've overdosed and they're actually coming, or if they're coming down, then they can actually have dilated pupils, and so sometimes it can be kind of hard to tell, you know, what type of drug before doing a UDS. A lot of folks, if they're kind of past the high and they have OD'd in, but they're still alert. There's always that window for them. The hyperemesis from the stimulation of the chemoreceptor trigger zone. They will just vomit and few things. Zofran and Phenergan usually don't touch them. And of course, respiratory depression if they have completely overdosed on these drugs, the respiratory depression that can lead to death. Behaviors, not so much symptoms that we see in patients for opiate abuse. According to the National Institute of Drug Abuse, opioids reduce the intensity of pain signals reaching the brain and affect those brain areas controlling emotion, which diminishes the effects of the painful stimulus. So, I mean, if you need these types of drugs, this is a really good a good action for this drug. So it's not just masking it, but it's just kind of it's making you feel good in the process, which obviously makes sense of why people would want to abuse them. It's just like endorphins with exercise. Endorphins make you happy, and these drugs mimic endorphins. So it certainly makes sense why people would want to abuse them, but obviously they can go down they can go down quite a path with them. Some of the behaviors, it can go anywhere from mania to depression, depending on what point they're at in their high or their low, or how long they've been abusing the drugs. They may have severe withdrawal symptoms, and their brain wants to be happy again. Again, those endorphins, if they're kind of coming down off of it, they can even just from the pills, not just a lot of times we think of people withdrawing from heroin or, alcohol, but even these prescription PO meds can cause the severe withdrawal symptoms. And then specifically as a behavior, if it's somewhere that they're presenting to that they expect immediate pain management, like an emergency department or an urgent care, they can get very angry if pain medicines aren't given right away, and if it's not the pain medicine that they specifically want, not that the prescriber wants to give them. Best practice interventions for healthcare providers that can implement, that we can implement to manage prescription drug abuse. First of all, just from the get-go, whenever we're prescribing medicines to patients for pain control, if it's their initial prescription, obviously it gets kind of tough with patients that are coming out of a serious surgery or something. But if it's for back pain, we don't want to just automatically give them narcotics for their back pain, or if it's their sprained ankle or something like that where there's no actual fracture. Start slow, start small with them, and try and get their pain under control before going to the harder narcotics. Another one is to assess for all drugs to help them recognize a problem. You can start with smoking and get them to open up about smoking, and then go to alcohol, have them open up about alcohol, then move on to something mundane to drug users, some marijuana, ask them about marijuana, see if you can get them to open up about that, and then move to whatever, any other addictions that they may have, or some of the harder drugs that they may be using, can kind of help them to realize if they have a problem or not. You want to watch for an unscheduled refill request and doctor shopping. I know that we have in the emergency department, we have a program in place where we, on admission to the emergency department, we request permission to speak to their pharmacy, which we all know that a lot of people that abuse drugs don't use the same pharmacy. They pharmacy hop, but sometimes that can at least be kind of a gateway for us to start finding out information about their records. Best practice interventions can go for a lot of different modalities of healthcare. One specific statistic that I found interesting, because I'm an emergency department nurse, is that 1 million ED visits in 2009 were for drug abuse, whether or not it was someone drug seeking, and that's only the people that we can actually hone down and identify as drug seekers, which we know that we see far more than we can actually diagnose as say are drug seeking. But whether it be ODs or withdrawals, there were 1 million emergency department visits because of drug abuse. So clinical practice, how do we address the drug substance abuse in our patients? I spoke about the admission questionnaire about their pharmacy. I know that when we are admitting patients for overdose, we have a CWA protocol, which is basically the withdrawal assessment that we do every hour to see if they need Ativan or Haldol, extra fluids, anything like that, to help them with their withdrawal, because serious withdrawals can be a major health concern for patients. If they can become severely tachycardic and dehydrated, and just so uncomfortable in their own skin, it can really start to kind of drive them crazy. As far as other clinical practice or specific situations that I've had, they're numerous. I don't even know that I could hone in on one specific encounter with patients. I've had people throw their discharge paperwork at me because they were not prescribed a narcotic. People that would get irate, pull their IVs out and walk out because we told them that we're not giving them a narcotic for their chronic back pain. Situations like that, it's almost on a daily basis, depending on what area I'm in or what acuity my patients are that day, the responses that I might have, but it's really almost a daily basis that someone is presenting to the emergency department and they're upset with the treatment plan for them, for their pain. And, we have very specific protocols in place. Our physicians are also on the Drug Abuse Warning Network, or DAWN. They will look up patients in a heartbeat to see, how many prescriptions they've had in the past couple months, or whatever, to see if they're drug seeking or not. And our doctors are really good about that. As I said, it's a safety issue for staff with these drug abuse patients, just because we kind of joke about, we do our mass or the active shooter, and we always say it's going to be one of these patients that didn't get the drugs that they wanted, that's going to try and come back for us, because they are, they can go that crazy not having their drugs. So we have to be careful. We have to be watchful of these folks, and do what's best for the patient, but also, not be an enabler of their disease as well. I personally have some mixed emotions about how we handle withdrawal. Obviously, I realize that it can be a very severe, even life-threatening event for some patients, depending on their withdrawal. But I've also had people come in that are on their second, third, fourth, fifth, sixth admission for withdrawal symptoms, and they come in demanding Ativan, demanding fluids, demanding, this and that, D50, Benadryl, to help control their symptoms. And to me personally, if you're always given these treatments for your withdrawals, and obviously it's always the people that are coming back for multiple times, there is a point where, should you not have to kind of, if you don't go through the withdrawal, then what is the, there's no incentive for not reverting back to these ways and to the drug abuse themselves. So it's a very touchy, tender subject for everyone. It's something that's extremely difficult as a healthcare provider. And obviously you don't want your patient to be in pain. So we want to relieve their pain, but we also don't want to be an enabler of their abuse. So I know this is not something that's going to go away anytime soon, and it's something that we'll be discussing for a long time. So I look forward to seeing everyone else's discussions. Have a great night.